talk about anatomy of renal system. First of all, we'll talk about our kidneys, ureter, urinary bladder and urethra. So let's start from the very beginning. First of all, kidney. The color of the kidney is reddish brown, and in Latin we call it rein or renal. And in nephron, these are the structural and functional unit of the kidney. There are 2.5 million nephrons in one human being, and due to inflammation of the nephron, that is called nephritis. We will talk about the structure of the nephron over here. Okay, please remember me. Then it's a retroperitoneal organ. As we know, we have discussed about retroperitoneal organs. The mnemonic is sad puckers. So kidney is a retroperitoneal organ present posterior to the present at the posterior abdominal wall, just along the sides of vertebral column. And if we talk about the location of the kidney, start from the T12, L1, L2 and L3. You can see over here. So this is T12, L1, L2 and L3. This is the location for the left and right kidney. And obviously the right kidney a little bit lower as compared to the left kidney because of the liver. The weight of the kidney in male is 150 gram and weight of the kidney in female is 130 gram approximately. And if we talk about the circumference or size of the kidney, it is 12 centimeter long, 6 centimeter wide and 3 centimeter thickness. And if we talk about the function, normal functions in order to remove the waste product from the body, it's a kind of you can say filter system of the body. It removes all the waste products. It removes or balances the water and salt, minerals, and it mainly balances the pH of the blood. And at the end, there is a movement of 2.5 centimeter vertically downward due to the contraction of the diaphragm. In erect position. In the erect position of a human being, the left kidney is narrower, longer and higher than the right kidney. Okay, the left kidney is narrower, longer and higher than the than the right kidney. So left kidney is higher, right kidney is lower due to the presence of the liver at the right side. So if we talk about the location, the left kidney is present, covered by the 11th and 12th rib, and the right kidney is only covered by the 12th rib. You can see over here like this. So left kidney is covered by 11th and 12th rib, and right kidney only covered by the 12th rib. And the distance between these two kidneys are 5 centimeter. And after that we have two poles, two surfaces, and two borders of the kidney. First of all, two poles. We have upper pole and lower pole. You can see over here. This is the upper pole of the kidney. This is the lower pole of the kidney. The upper pole is round and medial. The lower pole is thin and pointed. And if we talk about the lower pole, present 2.5 centimeter above the iliac crust, and we can palpate the lower pole if there is inflammation to the kidneys. Otherwise, it is very difficult to palpate the kidneys, and we palpate the kidney bimanually with our both hands. We palpate our kidneys. Then there are two surfaces, anterior surface and posterior surface. Then we have two borders, lateral border and medial border. In medial border, we have presence of vertical fissure that is called hilum. Vertical fissure at the medial border of the kidney. In the structures present in the hilum from front to back, that are VAP. Like renal vein, renal artery, renal pelvis, plus there is a presence of nerves and lymph vessels. Let's talk about the covering of the kidney. First covering is fibrous capsule. Okay, that is that is easily stripped off from the kidney if there is a normal kidney. But if the kidney is inflamed or any kind of pathology is going on, it is very difficult to strip off to remove the fibrous capsule. So the first covering of the kidney. Then second part is perirenal fat or perinephric fat that surrounds the fibrous capsule. Then we have third layer called renal fascia or false fascia or fascia of Ureter or Ureter's fascia. And it also covers obviously the second part. Plus it has two layers, anterior layer and posterior layer. Anterior layer is also called Told's fascia. You can zoom in. Told's fascia and fascia of Zuckerman. It is the posterior layer of the renal fascia or fascia of Ureter. Then last but not the least, we have fourth layer or fourth covering of the kidney that is called pararenal fat. It forms a cushion for the kidney and it fills the paracolic gutter. So that was about the kidneys. Let's discuss about renal pelvis. Renal pelvis is nothing but just a funnel shaped expansion of the superior part of the ureter. You can see over here, this is the superior, this is ureter, and this is superior part of the ureter. This is a funnel shaped expansion at the superior end of the ureter, and it divides into 2 to 3 major calyx. Okay, now I will give you a review about the exact landmarks. This is the ureter, the superior part expansion, renal pelvis. This is the renal pelvis. Very nice. And then it divides into 2 or 3. This is here we have 1, 2, and 3 major calyx, and each major calyx divides into 2 or 3 minor calyx. You can see this is the major calyx, third major calyx. It divides into 1, 2, and 3 minor calyx. So totally we have 2 or 3 in one kidney, 2 or 3 major calyx and 8 to 9 minor calyx. And there is no fun in telling. We have cortex and medulla. The outer part is called cortex, the inner part is called medulla. The outer part is cortex, that is dark brown in color. The inner part, that is medulla, that is light brown in color. And we talk about the pyramid. The base of this is the pyramid, okay. The base of the pyramid is towards the cortex, and apex of the pyramid is towards the medulla. And in between these pyramids we have renal papilla, and in between these major calyx we have renal columns. And here we have medullary rays. These are the medullary rays. These are the pyramids. So that is this is the capsule. Okay, this is the capsule. Okay, and then we have ureter, then we have urinary bladder, and then urethra. Let's discuss about. Okay, we have discussed about cortex and medulla, some relationships of renal pelvis. Anteriorly, right-sidedly. Right side of the renal pelvis, anteriorly there is a presence of right lobe of the liver. Obviously we have a right and left lobe, so right lobe present anterior to the right side of the renal pelvis. Then we have obviously we have right suprarenal gland. D2 means second part of duodenum, right fetal flexure, or you can say hepatic flexure, and jejunum. The left side of the renal pelvis, anterior relationships with spleen and its vessels, left suprarenal gland, pancreas, left flexure or splenic flexure, and beginning of the descending colon and stomach. If we talk about the posterior relationships of the renal pelvis, right sidedly we have there is a 12th rib, and left sidedly we have 11th and 12th rib. As I told you, left kidney is associated or related with the 11th and 12th rib, and right kidney is only associated with the 12th rib due to the imbalance at the level of these ribs. And there are common 4 muscles and 3 nerves present posterior to the renal pelvis. What are the 4 muscles? Psoas muscles, diaphragm muscles, quadratus lumborum muscle, and transverse abdominalis muscle. Then we have 3 nerves which are present posterior to the renal pelvis: the subcostal nerve, and iliohypogastric nerve, and ilioinguinal nerves. Let's discuss some clinical feature related with the kidney. Okay, 12th rib is resected obviously before surgery. If you want to do a surgery of any kind of pathology, nephrotic syndrome, nephritic syndrome, hydronephrosis, renal colic, or whatever, you have to resect or remove the 12th rib first. In order, there is a feature is danger of opening of the pleural cavity, because pleural cavity is present just between the 12th rib and the kidney. So in order to minimize the risk of damage to the peritoneum, which will cause the peritonitis, that is a surgical emergency, we supposed to remove the 12th rib first, then we go for the surgery. And then obviously we have to bimanually palpate the kidney. And if we talk about transplantation, the most commonly chosen kidney is left kidney, because due to having long renal veins, and we implant the transplanted kidney into the left iliac fossa. Okay, and obviously we will anasmose the arteries and veins. We will anasmose the renal artery with the internal or external iliac artery, and with the obviously the renal vein will be anasmosed with the external or internal iliac veins present at the right iliac fossa, and obviously the ureter will be connected to the urinary bladder of the transplanted kidney. Then renal pain, obviously we refer to the flank or loin pain, anterior abdominal pain, and groin pain. Due to these innervations, the flank pain is due to the subcostal nerve, and anterior abdominal wall pain or groin pain is due to the innervation by the ilioinguinal nerves. Let's discuss about renal angle. Renal angle, the outer border of the erector spinae muscle and lower border of the 12th rib. They make an angle called renal angle, due to which the pain of the kidney becomes a kind of dull ache. Then okay, if there is a fusion of the lower poles of the kidney, suppose there we have two kidneys, left and right like this, and if these lower poles are fused together, it make a horseshoe shape structure. So horseshoe shaped kidney due to the fusion of the lower poles of the kidneys, obviously is a congenital effect, and ureter pass anterior to the isthmus in order to prevent the upward ascent of these kidneys. Okay, let's discuss some other than the kidneys ureter. We have discussed about kidney, its size, its weight, its landmarks, its clinical features, and let's discuss about this part, ureter now. The length of the ureter obviously 20 to 25 centimeter. We have discussed the length of the esophagus, duodenum, and ureter is 10 inches or 25 centimeter in length, and 3 millimeter is the diameter of the ureter. 3 millimeter is the diameter of the ureter, and it is also a retroperitoneal organs. We have discussed a mnemonic set, fuckers. Please don't forget this mnemonic in order to understand and learn by heart all the organs present retroperitoneally. Then if we talk about the course of the ureter, it starts from the hilum. Obviously, we have discussed the medial border. Okay, if I make a kidney, okay, nephron, at the end we will make also. If this is the medial border, here we have hilum. Okay, a vertical depression or a fissure present in the medial border of the kidney. Starts from the ureter, starts from the hilum. Obviously, the superior funnel-shaped part of the ureter is called renal pelvis, and it will go to up downward and at the level of bifurcation of the common iliac artery, just at the level of sacroiliac joint in front of the iliac crust, and it enters into the posteriorly to the urinary bladder with an angle called lateral angle or oblique angle. Starting from here, hilum, and passing through the bifurcation of the common iliac artery and sacroiliac joint in front of the iliac crust, it enters into the bladder posteriorly, making an angle called lateral obliteratory or oblique angle. And obviously we have peristaltic movement in the ureter, muscular contraction, just like esophagus we have. Okay, then after that we have few constrictions or narrow parts of the ureter. There are total 5 narrow parts. Out of these 5 narrow parts, 3 are most common parts where we have, you can say the renal stone is mostly stuck. So first part or first constriction or first narrow part is pelvico-ureteric junction. Obviously pelvico-ureteric junction, the junction between the ureter and the renal pelvis. Then second one is at the pelvic brim, the area where the ureter enters into the pelvis, passing the pelvic brim. And third one is uretero-vesicular junction, the junction between the ureter and the urinary bladder. These 3 parts are most commonly involved in the renal colics. So urethral stones mostly occur or stuck at these 3 points. Fourth one, we have a deeper point or juxta part at the level of broad ligament and vas deferens, crossing point with the ureter. And fifth one, we have ureteric orifice. Now we will discuss about some relationship, obviously anterior relationship of the right ureter, D2, second part of duodenum, right colic vessels, ileocecal vessels, and in males we have right testicular vessels, and females we have right ovarian vessels, and we have root of mesentery. And anterior to the left ureter we have sigmoid vessels, left colic vessels, sigmoid mesocolon, and we have left testicular vessels in males and left ovarian vessels in females. If we talk about the posterior relationship of the ureter, you can say the posterior relationship of the right ureter, right psoas muscle, bifurcation of the right common iliac artery and genitofemoral nerve. And if we talk about the relationship of the posterior relationship of the left ureter, that is left psoas muscle, bifurcation of the left common iliac artery and genitofemoral nerve. Then we will talk about some structures which pass anterior to the pelvic part. In males, that is vas deferens, and in females, that is uterine artery. Then some clinical features related with the ureter. First of all, ureteric colics, stone in the ureter. The pain due to the upper ureteric obstruction will refer to the lumbar region due to the innervation by the L1 and L2. The pain due to the middle ureteric obstruction will refer to the inguinal part due to the genitofemoral nerve, and it also refers to the scrotum, mons pubis, and upper and medial aspect of thigh due to the L1 and L2 again. Then thirdly, we have the pain due to the lower ureteric obstruction. The deferred pain will go to the perineum due to the innervation by S2, S3 and S4. Last but not the least, we have 4 danger sites of ureteric injury. The 4 danger sites where the ureter can be injured. Number 1, where the ureter crosses the iliac crust. Number 2, at the base of the bladder, obviously the urinary bladder, not gallbladder. And third one in ovarian fossa, and fourth one where the ureter crosses uterine artery. While doing the hysterectomy, there are chances that you will injure the ureter also, and that is the most dangerous site for the ureteric injury or rupture. Now we will discuss, after the ureter, we will discuss about urinary bladder. Now we can see over urinary bladder. If we talk about the shape of the urinary bladder, it differs from the filled and empty. If the urinary bladder is empty, then the shape of the urinary bladder is pyramidal in shape and it will lie in the pelvis. Not with the children. In children, the urinary bladder is present in the abdominal cavity. Okay. And if we talk about the full urinary bladder, the shape of the full urinary bladder is ovoid in shape and it will extend upward into the abdominal cavity till the umbilicus. If we talk about the capacity of the urinary bladder, it's almost 500 ml, but when the urinary bladder is filled till 300 ml, then due to the muscular stretchness, the urinary muscles which are making the walls of the urinary bladder, they stretched due to the if there is a 300 ml fluid in the urinary bladder, it will give a signal to the CNS, and from where there is a you can say the output will come, and through pudendal nerve and all these mechanisms, there will be continuous desire to micturate. You can say conscious desire, not continuous, conscious desire to micturate, to urinate. And we use cystoscope in order to check or see or visualize the interior of the urinary bladder. We use cystoscope. Obviously, we go through the urethra. And we have anatomical reflex bladder where there will be a contraction every 2 to 4 hours of the bladder. Then we have some external features and some internal features of the urinary bladder. Some external features are apex. Apex is connected to the umbilicus with median umbilical ligament, that is a remnant of embryonic urethus. Then we have base or fundus. The base or fundus posteriorly in females associated with the uterus, cervix and vagina. And this base or fundus posteriorly in males, we have upper part and lower part. Upper part associated with, separated from the rectum by the retrovesicular pouch, and it contains the coils of intestine. And if we talk about in males, the posterior aspect of the base or fundus of the urinary bladder, lower part associated with, it separates from the rectum by seminal vesicle and termination of the vas deferens. And thirdly, we will talk about the neck. After the apex, base, now neck of the urinary bladder, it is the lowest and most fixed part. Don't forget this, it is the most fixed part of the urinary bladder, the neck of the urinary bladder. It held in position in males by puboprostatic ligament, plus it is having a highest number of alpha receptors. Then we talk about in males, the neck, it rests on the base of the prostate gland, and in females, it is present above the urogenital diaphragm. Now we will talk about some superior surface and inferior surface of the urinary bladder. These are the external features again. Superior features in males, superior surface in males, it is covered by peritoneum and it contact with the sigmoid colon and terminal colon. These are the contact parts. Terminal ileum, sigmoid colon and terminal ileum. In female, the superior part is not covered by peritoneum except vesico-uterine pouch. If we talk about the after the superior, if we talk about the inferior part, okay, this is the inferior. If we talk about the inferior part, it is devoid of peritoneum. In front, it is related to the retropubic space and pubic symphysis, and in behind, it is related with the obturatus internus above and levator animus below. These are the external features of the urinary bladder. Let's discuss some internal features of the urinary bladder. There is a presence of trigone. Suppose this is a trigone. Present at the base of the urinary bladder with a triangular area present above and behind the internal orifice of the urethra, and ureter opens at the posterolateral angle of the trigone, and the opening are 2.5 centimeter. They are apart from each other, the opening of the urethra and the trigone. And we have interureteric ridge also, that is also called bar of the Mercier, and we have urethral ridge also, that is also called Bell's bars. Now we will talk about some ligaments of urinary bladder. We have some true ligaments and some false ligaments. True ligaments, we have two lateral true ligaments, we have two lateral puboprostatic ligaments that will fix the neck of the urinary bladder. Then we have two medial puboprostatic ligament, then we have two posterior ligament and one median umbilical ligament. These are the true ligaments of the urinary bladder. Now let's discuss some false ligaments of the urinary bladder. The false ligaments, there are 7 in number. They are nothing but just a peritoneal fold and they have no support to the urinary bladder. There are two median umbilical ligament, two lateral ligament, two posterior ligament, one median umbilical folds. So these are some true and false ligaments of the urinary bladder. There are some features of internal sphincter and external sphincter. Internal sphincter present just at the neck of the urinary bladder and external sphincter present at the membranous urethra. Let's discuss these things one by one. First of all, internal sphincter, that is also called sphincter vesicae. Then we have external sphincter, that is also called urethral sphincter. If we talk about the nature, the internal sphincter, that is involuntary, not under our control. But the external sphincter is it's a voluntary, in our control. Then if we talk about the muscles associated with the internal sphincter, there is smooth muscle, that is also called detrosal muscle. The muscles of external sphincters are skeletal, also called sphincter urethra. The presence, the internal sphincter in males present, it will prevent the retrograde ejaculation, and in females there is absence of this proximal sphincter in females. Obviously we have distal sphincter in females, but in males we have proximal plus distal sphincter, and proximal sphincter is present in male that will prevent the retrograde ejaculation of semen, obviously. Then we have surrounding the internal sphincter, it surrounds the neck of the urinary bladder and prostatic part, and external sphincter, it surrounds the membranous urethra. Last but not the least, supply. The internal sphincter supplied by sympathetic nervous system, and the external sphincter or sphincter urethra are innervated by the parasympathetic nervous system, more specifically S2, S3 and S4. Let's discuss last but not the least our urethra part. First of all, male urethra, then female urethra. Male urethra are responsible for seminal semen ejaculation and micturition. We have spadias in urethra. Obviously male urethra most commonly, epispadias and hypospadias. Suppose this is we have a urethra, and if there is an opening of the this is the penis of a male, obviously, and if the urethral opening is not over here, it is present somewhere here or here, that is called epispadias. Epi mean above, epispadias. And if the urethral opening is present over here or here or here, that is called hypospadias. That is very important thing you must not forget. Let's talk about some features one by one. We have 3 types of male urethra, right? Prostatic part or prostatic urethra, membranous urethra and spongy urethra. This is the membranous urethra. First of all, location. The prostatic part of the urethra or prostatic urethra present within the prostate gland. The membranous part present within the urogenital diaphragm, and spongy part or penile part of urethra is present within the penis, more specifically corpus spongiosum. We have corpus spongiosum and corpora cavernosa. Then we talk about the size. The prostatic part is 3 cm, the membranous part is 1.5 to 2 cm in length, and spongy part is 15 cm in length, or penile part is 15 cm in length. If we talk about the diameter and dilatability, the first part, the prostatic part, is most widest and most dilatable part. The membranous urethra, it is most narrowest and most, or you can say, least dilatable part. And the penile urethra is uniformly diameter with median dilation. It is obviously a uniformly diameter, and there is opening of the bulbourethric gland opens at the spongy part or penile urethra just below the urogenital diaphragm. If we talk about the opening, the prostatic urethra opens. We have a prostatic atrial, ejaculatory duct and prostatic gland. Opening of the membranous urethra is minute mucus glands, and opening of the penile urethra, we have a urethral glands are called Ureter's gland. Last but not the least, we will talk about some other features related to the prostate part. It is a horseshoe-shaped part in cross section. Obviously, the membranous urethra is star-shaped part in cross section. It is the shortest part and most common site for urethral carcinoma. And we have lastly, we have penile urethra. This is a trapezoid shaped in cross section, and this is the most common site for injury or any stricture. Let's discuss some female urethra. Female urethra location, it begins at the neck of the urinary bladder and passes through the urogenital diaphragm, opens into the vestibule of vagina in front of the vagina just below the seminal vesicle. If I can show you over here, suppose here we have clitoris, here we have urethral opening, here we have vagina, and here we have anal canal. So this urethral opening is present in front of or in the vestibule of the vagina just below the clitoris, that is the female urethra. Clitoris, and the size of the female urethra is 4 cm in length, and in vaginal stretching during childbirth, the length of the urethra may extend to the 10 cm, from 4 to 10 cm, and there is a urethral lacunae, a pit-like mucus recess present along whole length of the urethra. If we talk about some glands, we have a para-urethral gland of Skinnies that are just alternative to the prostate gland in females. That paraurethral gland of Skinnies opens at the upper part of the urethra. Now we'll talk about some clinical features. Injury. Okay, if there is an injury above the urogenital diaphragm, then there will be rupture of the membranous urethra, and if there is an injury below to the urogenital diaphragm, there will be rupture of the bulbous urethra. UTIs, obviously. Now you can go back a little bit. UTIs are more common in females as compared to males. There is something like in females due to the short length of the urethra, because in males the size of the urethra is almost 20 cm or above, and in females it is 4 cm length. So due to the short length of the suppose this is the length of the male urethra and this is the length of the female urethra. So due to the short length of the urethra in females, the UTIs are more common in females, plus due to its location. This location of the urethral opening is present just in front of the vaginal vestibule or vagina and below the clitoris, or you can say the opening is just near to the vaginal opening and the anal opening. That is why the UTIs are more common in females. If we talk about some, okay, there is a posterior urethral wall that is the most common site for obstruction in children. Posterior urethral wall is the most common site for obstruction in children. Then let's discuss about some catheterization in male and female. Obviously in males, suppose this is the penis of the male, you have to gently take this penis and you have to pull upward so that the S-shaped mucous membrane of the penis becomes J-shaped, and obviously the first of all opening, urethral opening is most narrowest part. And then you will obviously you have to use the aseptic measure, you have to use gloves, and you have to use lignogen gel to the gloves, to the penis, to the Foley's catheter also. You have to pass through the narrowest opening of the urethra, then downward. Then you will have a navicular resection or dilated part of the urethra, then you will go downward. And for females, the catheterization is easy due to two reasons. One reason is the short length of the urethra, and second one is the wide diameter of the urethra. So that was about urethra, its some clinical features. Is there anything I left behind or you want me to explain?
No, sir.
Okay, thank you so much.